Good afternoon. One more time in front of you, but this was a last minute reallocation for someone who's dropped out. Okay, so there's shifting paradigms, but I think in this case it is like more like a yo-yo. It sort of swings from one end to the other and comes back. So when you are giving fluid therapy, what are your goals? One is you want to correct hypovolemia. You want to obviously restore organ perfusion, correct tissue perfusion. You also want to avoid complications related to hypoperfusion. At the same time, you want to avoid complications related to fluid therapy. And the complications related to fluid therapy depend on the volume and rate of fluid you infuse, as well as the type of fluid you infuse. And I think we've seen significant changes in both these concepts of complications of fluid therapy. When I was in training, and for many years after that, we had to give a lot of fluid. I mean, if you resuscitated, you gave fluid. Right, and they said fluid is good, and there were things people used to say like, if you want them to get well, they got to swell, and that sort of thing. So you give a lot of fluid, and some of it was also driven by protocols like the early goal-directed therapy protocol of Rivers. So where you actually gave fluid targeted to a CVP of about 8 to 12 millimeters of mercury, and then the arterial pressure and SCVO2 and so on and so forth. But a lot of the emphasis was given on adequate fluid resuscitation, and adequate was defined in various ways. And one of the more sophisticated ways was guided by wedge pressure or guided by the CVP or something like that. Okay, and it's not uncommon. It's not just us India, but all over the world. So this was a study on fluid challenges in the ICU, and they studied over 2,000 patients who got a fluid bolus, and they found that the median bolus size was about 500 ml. It was given over roughly 25 minutes, and the rate of the fluid challenge was about 1 liter per hour. So in half an hour or so, they gave about 500 ml, and that was the main way in which fluid boluses were given. The main indication was hypotension. So if the BP dropped, that was a trigger to give a fluid bolus. In 43% of patients who got a fluid bolus, this is all over the world, not just in some place in some third world country. In 43%, no hemodynamic variable was used to monitor the fluid challenge, whether it was effective, not effective, or whatever it was. Only hypotension, give fluid. Static markers, which means CVP, was used in 36%. Dynamic indices, which we'll talk about, were used in only 20%, 22%, right? So the ones which we think today are the better indicators of fluid for giving fluid were used in very few patients, and safety limits for giving fluid were rarely used. So it was just arbitrary: hypotension, give fluid bolus, and that was it. And if people did not consider whether the previous fluid bolus had worked or not worked. So in other words, it was all very arbitrary, and all over the world people are giving fluids in a reasonably more or less arbitrary fashion based on hypotension. So hypotension used to be one trigger for giving fluid. The other trigger was oliguria. Patient has less urine output, let's give a fluid bolus. So this is a new article which is coming out in intensive care medicine. False beliefs that one of the things at a fluid challenge is always recommended in patients with oliguria, and which is what many people practice, and that's why it's a false belief. But remember that you should give fluid only if it's going to increase the cardiac output, not because the urine output is low. If the cardiac output is not going to increase, you should not be giving fluid. And if a fluids will increase cardiac output in patients who are what we call as fluid responsive. So you should give fluids only in patients who are fluid responsive. Secondly, if your blood pressure is low but your CVP is high, okay, then what happens is your perfusion pressure, the diastolic perfusion pressure of the kidney falls. So with a low diastolic pressure and a high CVP, diastolic pressure minus the CVP, the perfusion pressure of your kidney falls, and you can actually get worse renal injury. Okay, so giving too much fluid in someone who's got a low blood pressure, the CVP rising but not the cardiac output, can actually be detrimental. So please remember that you should give fluid only to patients who are fluid responsive. And what is fluid responsiveness? It is a state where administration of fluid will lead to improvement in stroke volume and therefore the cardiac output. So fluid should be given to improve cardiac output. If fluid is unlikely to improve cardiac output, you should not be giving fluid. What happens if you give fluid to patients who are who do not require the fluid? So what happens if you give too much fluid? And many studies, and this is just one study which I am showing you, which is a retrospective study anyway, unfortunately, prospective analysis is an observational study, is that a SOAP study in Europe, cumulative fluid balance was clearly associated with a worse outcome. So giving excessive fluid is detrimental. Okay, and it will be surprising if you see that if you look at septic patients, you think that septic patients require a lot of fluid, but in this, multiple studies have shown that on an average, only half the patients who got severe sepsis or septic shock are fluid responsive. In other words, 50% of patients, if you give them fluid, they will respond by increasing cardiac output, so the fluid was justified. In the other 50%, if you have given fluid, it has had no hemodynamic effect and therefore is totally unjustified and can only add to the fluid load without doing any benefit. So even in a condition like severe sepsis or septic shock, you should be careful and give fluids only in patients who are fluid responsive, right? Now it is any other, the commonest parameter which many people use is the CVP. The unfortunate problem of the CVP is it does not predict whether the patient is fluid responsive or not. And this is a very beautiful study. So these are patients, responders who increase cardiac output after giving fluid, and these are non-responders who did not increase cardiac output after giving fluid. And you can see there is no difference in the scatter of CVP values between responders and non-responders. In other words, you cannot use the CVP to decide whether your patient is going to be fluid responsive or not. How can you make out whether a patient is fluid responsive? You use what we call as a dynamic indices, and they depend on the position of the patient on the Frank-Starling curve. A patient who is on the steep part of the Frank-Starling curve will increase his stroke volume in response to fluid. Someone who is on the flat part of the Frank-Starling curve will not increase his cardiac output in response to fluid. Okay, and you can do it by various tests like the pulse pressure variation, IVC diameter, enduring controlled ventilation, and what we recently described as the tidal volume challenge, or you can do the passive leg raising test. Now I don't have the time to go into all these tests, but these are the dynamic tests which predict even before you give fluid whether or not the cardiac output will increase in response to fluid loading. So if the pulse pressure variation is high, higher than 13% or 14%, it suggests, so it's a swing in the blood pressure tracing that you get. If there's a high swing, it suggests that the patient will increase the cardiac output in response to fluid loading. And you should use these dynamic tests to decide whether or not to give fluid. And pulse pressure variation is present on many of the monitoring systems that you have. So the Philips monitors will display pulse pressure variation, and you need to just maybe ask your engineer to help to turn on the parameter. It's inbuilt into the software, and if the pulse pressure variation is say more than 14 or 13 or 14, it suggests that the patient is fluid responsive. So that means you should give patients fluid only if they are fluid responsive. Unfortunately, like you saw in the Phoenix study, very few patients use dynamic predictors like this, and most of them relied either on CVP or nothing at all, and that was the unfortunate problem. Okay, so the CVP has taken a bit of a beating. One is for this reason, and secondly, many other studies which have shown that protocols which include the CVP as a monitoring tool have not really made a difference to outcome. Okay. The other thing which we need to think about, or the way we give fluid, is a fluid bolus. Now we traditionally give fluid boluses, right? Blood pressure is low, patient is fluid responsive, okay, give a fluid bolus. Now there's a very interesting study which came some years ago. It was a study of in Africa, in children in Africa. Now these people had malaria and some of those tropical illnesses. They did not have an ICU. The only thing they could get was oxygen. There was no ventilation, there was no hemodynamic monitoring, no CVP monitoring, arterial pressure monitoring, nothing. So these were patients with severe febrile illnesses and impaired perfusion, and they were randomly assigned to receive either albumin bolus, a saline bolus, or no bolus. And the authors actually wanted to demonstrate the superiority of albumin bolus over the other sort of things. Okay. So they enrolled over 3,000 patients. Okay, 1,000 got an albumin bolus, 1,000 odd got a saline bolus, and other patients got no bolus. And to the big surprise of these authors and most of others, the ones with the no bolus had the best result, the best outcome. Both the albumin and the saline bolus were associated with the worst outcome compared to no bolus. Right? So they concluded that fluid boluses increased 48-hour mortality in critically ill children with impaired perfusion in resource limited setting in Africa. Remember, they had no backup of ventilation, they had no backup of they had no monitoring of any kind. But if you gave them fluid boluses, they did badly. So it means several things can be sort of learned from the study. You're not saying you should never ever give a fluid bolus, right? Only in intravascular compartment, doesn't cross the endothelial membrane and doesn't go into the interstitial space. So if you give 100 ml of normal saline, it will be distributed between these two compartments, so you will have about 25 remaining in the intravascular compartment and 75 ml will be distributed into the interstitial space. Whereas if you give albumin, all of it will be retained within the intravascular space. This is assuming all the membranes are intact and there is no other problem with the endothelium. And this has been the physiological basis of saying that to achieve the same degree of volume expansion, you need 3 times as much crystalloid as colloid. And that's why if your patient is sick, he's hypotensive, you want to get the BP up fast, give him colloid. Because in a short time with 100 ml, you will get the effect that will, for which you will need 300 ml of crystalloid. But if you look at most of the studies, the big trials which have been done in critically ill patients, and you look at the ratio of crystalloid and colloid that they have given to in the two groups, they are nowhere near 1:3. They are probably in the range of 1:2 to 1:4. So at the most, you need at the most 1.5 times as much, and maybe even less than that. So you don't really need. So in sick patients, maybe where the endothelium is little leaky, where even albumin leaks out or some colloid leaks out, maybe these ratios do not hold true, and you don't really need to give as much colloid, as much crystalloid as colloid, and therefore you could actually get away with giving only crystalloid. Right? You don't need, if you can make do with 100 or 120 ml, why not give crystalloid? It's cheaper, it's faster, readily available. Okay, so this seems to be the thing that is coming up, that you don't need as much colloid as crystalloid. So that's one of the things that has changed, is that you don't need, in sick patients, you don't need 3 times as much crystalloid as colloid to achieve a hemodynamic effect. It's probably less than 1.5 times. Now, in the late 90s, there was this meta-analysis which was published in the BMJ and which took the medical world by storm. And this was a meta-analysis of all sorts of trials, pediatric, burns, critically ill, etc., etc. And it suggested that albumin, if you gave albumin to patients, it resulted in higher mortality. And that was a big blow, because albumin was a very popular colloid in the West at that point in time. It was never popular in India because it was far too expensive, but it was very popular in the West, and that was the default sort of colloid to go to. And when they found that albumin was associated with higher mortality, the press went crazy, very much like the press is going crazy today, that albumin kills and doctors are killing patients and etc., etc. And so people were very alarmed. And what the Australia New Zealand group did was they did this massive study called a SAFE study. They got thousands of patients who they randomized to either receive saline or albumin, and what they were able to show is that there was absolutely no difference in mortality, whether you gave albumin to critically ill patients or you gave saline to critically ill patients. Now, it was a big relief, because at least you knew that albumin doesn't kill and you could safely give albumin, but it also means that if there's no difference in mortality, why do you want to give albumin? Just give saline, right? So it could be interpreted in either way, but at least albumin was not a dangerous molecule. In India and in many other places, because albumin was expensive, difficult to source sometimes, the synthetic colloids were very, very popular. And at one stage in our ICU and in our operating rooms, we were using starches left, right and center. Okay, anyone with any hypotension, very much like the Phoenix study, give 250 ml of starch. Bleeding patients, starch. Hypotensive, in OT, starch. Anything, it was starch. Sepsis, starch. There was one red flag in a German study, but they had used a very old molecule of starch. We all knew that starches had side effects like coagulopathy, a little renal dysfunction, but nobody thought it was very significant. Until this study came up from Scandinavia. It was called the Success study, where they randomized patients to either starch or ringalactate. And what they found, at the safest starch that we knew at that point in time, HEST 130 by 0.4, had a higher risk of death and were more likely to require renal replacement therapies. This was a big red flag on starch. And then there was another study which came from Australia and New Zealand called the